This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Shuvro Roy from the University of Washington, and welcome to today's Neurology podcast. We'll be discussing a new study published in Neurology titled Consensus Recommendations for the Management of Neurosarcoidosis, a Delphi survey of experts across the United States. Neurosarcoidosis is, of course, a remarkably challenging condition to treat, given its rarity and lack of consensus guidelines on both approach to treatment and treatment monitoring. We're fortunate enough today to be joined by the lead author of the study, Giovanna Manzano, a neuroimmunologist at Mass General Hospital and Brigham and Women's Hospital. Giovanna, thanks for joining us.
Yeah, thank you for having me, Shuvro. I'm very excited to be able to speak on this manuscript.
So take us through what motivated you and your team to focus on developing these consensus recommendations for the management of neurosarcoidosis.
Neurosarcoidosis is challenging. We only somewhat recently in 2018, as a field, developed these consensus diagnostic criteria, which are really based on level of certainty and often very much fueled by pathologic evidence to support sarcoidosis, either directly in the nervous system, systemically, or in the possible category of excluding everything else and fitting clinical and radiographic features. And I think that alone was a huge move forward for this condition and our ability to really treat, because now we have this framework of how to diagnose this very heterogeneous condition, which we're all taught is the great mimicker, right? Neurosarcoidosis can look like so many things because it can affect really anywhere in the nervous system. But what we're left with is really, how do we manage these patients? And so when there was a lot of momentum to talk about this amongst a group of people in the national community that take care of neurosarcoidosis, I jumped at the opportunity to gather us all together and formally put this together.
I want to get into the key points and the framework that you referenced, but I was wondering if you could quickly take us through the main challenges that providers often face when trying to treat this condition.
This takes us even zoning out a bit from just treatment only, right? The challenges of diagnosis are very real and at times frustrating because we lack reliable biomarkers to diagnose neurosarcoidosis. The majority of cases that we have often tend to fall into this probable neurosarcoidosis category, meaning there's some evidence of extraneural sarcoidosis that's been biopsy proven, a neurologic phenotype that is consistent with what we know neurosarcoidosis can do. But beyond that, looking for certain blood tests, certain levels in the spinal fluid is still very much a work in progress. We are challenged with defining what is this condition, and then in facing that, being confident and knowing how to move forward with treating it can feel a bit overwhelming at times when you're not as able to say, yes, I have all the data to say this is it. Let's go now to a very strong medication that has a lot of infectious risks and complications. It's something that we face broadly in neuroimmunology, but something that it's important to really come to a head with and say that we developed a certain degree of diagnostic certainty. Let's move forward. And I think beyond the challenges within the diagnosis realm, certainly another challenge that's somewhat related to that is the lack of a standard approach at the present time in terms of how do we really surveil treatment response. And there's something inherent to neurosarcoidosis that I'll just touch upon briefly, which is this mismatch at times between clinical response to treatment and what we find on serial MRIs. We very much appreciate the value of using gadolinium contrast when we want to assess this disease acutely and to interval repeat imaging. We also want to use contrast to be able to see how the condition is responding. But in neurosarcoidosis, it's somewhat unique in that there's often this lag where clinically a patient may be responding, but the imaging has this persistent contrast enhancement even beyond. And it's just hard to know, is the MRI even the right metric to use to really assess treatment response?
Well, I want to get into the really excellent stuff that was outlined in this study. Could you take us through the overarching key points you learned from this work?
The most, I think, important key point to take away from this paper is an argument for the shift in the way that we think about an approach to treating neurosarcoidosis. At present, there's variability. So for some, the practice of starting with steroids and then escalating upwards, and by that I mean moving then from something steroid sparing in addition to the steroids at a moderate and then a higher effectiveness, is something that has been applied. And certainly the European guidelines that were published not too long ago in 2021, largely devised by pulmonologists and rheumatologists, touch on this. And, in the pulmonary world, this escalation approach is the common practice. And I think what our paper challenges is that neurosarcoidosis is a bit different. There is a very high likelihood of some irreversible damage that we see, particularly in certain phenotypes, such as myelitis or CNS parenchymal disease. And in the nervous system, with these tissues, we need to act fast and to try to stop and quell whatever inflammatory process is ongoing at that moment in time to ensure that we can get ahead of what otherwise will be potentially irreversible damage and thereby functional limitations to the patient. And to put into practice, this ideology, one outcome of this Delphi survey that we queried these experts from 19 different institutions was that you really should focus on the phenotype of neurosarcoidosis and the severity of that phenotype as a means to gauge what your initial first-line acute treatment regimen should be. By this, we acknowledge in prior retrospective cohort studies and many other ongoing collaborative descriptive studies that there is a range within neurosarcoidosis when you really break it down by phenotype in terms of how responsive neurosarcoid is and what an end functional outcome may look like. So for patients that have your more peripheral manifestations, let's say a facial palsy from neurosarcoidosis, it's very well described in literature and in clinical practice as well that those patients tend to respond pretty excellently to steroids alone and arguably don't require any sort of maintenance treatment. Once their facial palsy acute attack is resolved, the risk of recurrence is quite low. And this greatly contrasts with somebody who has the same disease, neurosarcoidosis, but instead of affecting cranial nerve 7, it and then instead goes for cranial nerve 2 and causes an optic neuritis, which within this phenotype has a range of severity. As a caveat, as a field, we actually haven't come together to define what is mild, moderate, and severe within these phenotypes. But in our paper, we do propose a framework to really refer to. So when you are able to go and look at the manuscript, you take a look at our methods section where we define what mild optic neuritis is, what moderate and severe optic neuritis is. We looked at what the common cutoff was for visual acuity and driving laws as a way to gauge this. And so for us, it was acuity worse than 20/60, would then put you into the moderate severe category, whether or not it was unilateral or bilateral. And the details, again, are in the paper. But those patients, are at high risk of having permanent visual impairment. And so it feels almost a disservice to imagine that you could apply the same treatment approach to a facial palsy that we know is going to be steroid responsive to someone with a neurosarcoidosis-related optic neuritis, which has the potential to leave them with permanent visual impairment and even blindness. And in practice, we know that those patients, especially with the moderate to severe grade severity, don't respond soon or well enough to corticosteroids. And so it is justified to then say, well, at this juncture, instead of waiting and seeing how they respond, we're going to go ahead with something that we know to be stronger. And in this type of situation, we had a very strong consensus for different phenotypes of more severe outcome potentials, I'll say, to say that up front, you should start with both steroids and a TNF-alpha inhibitor, particularly infliximab. And the argument for infliximab is based upon retrospective series, meta-analyses of what's in the literature. Certainly, a limitation we have at this present time is the lack of randomized controlled trials. It's just too rare of a condition and very complex, and we're only beginning to start to organize our approach here. And hopefully in the somewhat near future, we can have some RCTs for this condition. But at the present, using this survey study as a means to be able to justify our approach is impactful. And so I think the key point really to summarize that is, who is your patient? Where is the neurosarcoid affecting it and how severe it is? Taking that into account to guide your treatment is actually a novel argument that we're making here, and a very important one.
That point on understanding the spectrum of disease, I think, is so understated or has been understated in much of the work to date. I think about literally the two last patients I had with neurosarcoidosis, one of whom had essentially asymptomatic posterior fossa leptomeningeal enhancement. And is that the patient you treat the same as, for example, the other patient I saw who had, just as you described, a severe optic neuritis that left them blind in one eye after a single attack? And I think that's such an important point of this paper, is this inductive approach with anti-TNF alpha inhibitors for those severe phenotypes, especially early on in the treatment, rather than taking an escalation-based approach. I was wondering if you could, briefly take us through how you might do that for a patient with a severe clinical phenotype.
In neurosarcoidosis, this condition very much responds to steroids, but you can imagine that the course duration needed to have sufficient response in these severe phenotypes is going to be extremely long, not tolerated, and put the patient at high risk of toxicities, and arguably not sufficiently effective because we're not going to get ahead enough of the inflammation. So while we're giving this patient the high-dose IV steroid, we then follow it by oral prednisone, typically at a dosing of 1 milligram per kilogram of the patient's weight, and continue onwards with a slow steroid taper. How slow? What does slow mean? This is where it's a bit nuanced, and you think about who's your patient, what's their response clinically. If you have an imaging finding that you're following, how is that changing? And arguably, really, perhaps relying more on the clinical, because we spoke a bit earlier about how the imaging may not fully be up to speed with where the disease state is. But while that is ongoing in the background, perhaps somebody is on prednisone 60, let's say, for 14 days, and they start tapering by 5 milligram decrements weekly, as an example. You are then simultaneously, while they're having their pulse dose steroids up front, are going to give them a high efficacy treatment for neurosarcoidosis. And, I do want to share this disclaimer, which is important to note, that we as a group feel that infliximab being referred to as a highly effective therapy in neurosarcoidosis is justified by anecdotal experience, retrospective cohort reviews, such as a study by Dr. Gelfand and his colleagues, which looked at this inverse relationship from time to infliximab and overall prognosis, which was in favor of infliximab and timely administration of this. So again, just to acknowledge, we lack those more standard RCTs, but there's data out there to show that clinical experience is supported and justifies the outcomes of our survey study. The dosing that we use for infliximab is really borrowed from our colleagues in rheumatology, and you would essentially load the patient up front, giving them typically 5 milligrams per kilogram of infliximab according to their body weight at weeks 0 to 6. And then for the maintenance treatment, we typically continue onwards with this 5 milligram per kilogram dose at a frequency between every 4 weeks to every 8 weeks. And this range, again, is reflective of the variability that you have to permit as you are assessing what is the severity of this phenotype, what is this phenotype, who is this patient, what are those comorbidities, how unbalanced is the benefit versus risk ratio. And putting all those factors together to really give an individualized treatment plan. So there definitely is not a one-size-fits-all, but that's the general framework that I could share for dosing.
I think that is one of the key takeaways of this study, is that consensus towards using infliximab for those severe phenotypes. I also want to touch on, we've spoken about, variability even between institutions and providers and treatment of this condition. And your study also highlighted those areas where consensus was not achieved, whether it was duration of a steroid-sparing therapy. How should clinicians navigate some of those gray areas?
It's very challenging. This is where exposure to management of neurosarcoidosis is then in someone's favor. But the reality is that many of us, even those included in this paper, may not see an abundance of patients with this condition. Even within our paper alone, only about slightly more than a third of the expert respondents have actually taken care of more than 50 patients with neurosarcoidosis. So it's a rare condition. To navigate these gray areas, dependent upon the actual circumstances, I think there are times where consulting and collaborating with rheumatology, let's say, is essential. So if this patient has systemic sarcoidosis, but also a neurosarcoidosis manifestation, working in conjunction with rheumatology actually is going to be helpful to really know, how do we manage both sides of this disease? I'm focusing on the neurologic manifestations, but I know there's more extraneural processes ongoing, and working together to be able to monitor and surveil treatment response of not just neurosarcoidosis, but the other organs that are affected as well. And together, a treatment plan can be made in a reasonable fashion. I would say, broadly speaking, although you're correct in that we could not come to a consensus on the exact dosing regimen that could be followed, I think it truly reflects the patient population that we're managing here, that not everybody responds to what is a perfectly aggressive treatment plan for one patient. The next patient may have the same phenotype and just not respond at the same rate. And is there a variability of time to treatment that's at play? Is there something unique about the time in someone's life, their comorbidity? These are so many interesting unknown questions we have as to why there's variability even within the same phenotype, even within the same severity range. But a slow steroid taper is what you would aim for. So slow meaning weekly changes, really. Arguably, 10 milligram decrements may be a bit bold and brazen if somebody is severely impacted by a phenotype that could leave them with permanent functional mobility. But the way to offset that is to really closely monitor your patients. These are the patients that you want to be sure you're checking in with often. You want to be sure that even if you have a scheduled plan for repeat MRIs every 6 months, that your clinical intervals of following them, doing their exams, assessing their symptoms happen at a much greater frequency than that. In my own practice, when I have patients with severe and concerning phenotypes such as myelitis, let's say, or severe optic neuritis, at the very beginning, especially as I'm weaning prednisone, I like to see the patient somewhere when they're reaching 40 to 30 milligrams of prednisone, because anecdotally, that's when, if they're going to kind of break through their current regimen, that you might catch something. And you might have to say, we have the infliximab loading doses going, and we're in the process of that, but you're just not ready to continue down on the prednisone right now, because now I see on your exam this, or you're experiencing this symptom, and this is worse than the last time I saw you. So these are patients that you certainly need to be a bit more attentive to, not only in being sure that their clinical stability and hopefully improvement is something that continues onward, but being very watchful for any new symptomatology, any recurrent symptoms, while in the background also thinking about infectious complications. It's a bit of a juggle, right? There are a lot of factors I just threw at you all, but a slow steroid wean, an appropriate induction approach with a very powerful agent such as infliximab will be more likely to preserve the patient and ideally reverse some of the injury that the neurosarcoidosis can cause. The hypothesis is if you use this early enough before permanent irreversible damage occurs.
I'm so glad you mentioned the importance of a multidisciplinary team. Patients with neurosarcoidosis often represent really anywhere from, I believe in the paper you mentioned, even 5 to 15% of patients with sarcoidosis as a whole. And so it is quite likely that they have other organs involved, whether you needing to see a pulmonologist or rheumatologist, as you've mentioned. I've certainly worked with cardiologists, and I totally second your point that it is not uncommon that we need to adjust those steroids, particularly if, as you mentioned, with a patient with myelopathy who may be clinically worsening with a taper, to then unfortunately go back up on those steroids if that's what's necessary to keep them clinically controlled. You've touched on this already, which is the lack of randomized control trials to date for neurosarcoidosis, and even anecdotally, we in our own institution, while we see plenty of patients with this condition, it is still too rare for us to probably put together a large cohort study. How, from your perspective, can we continue to advance research in this field with such a rare condition?
I think it all boils down to collaboration and collaboration again. Fortunately, in recent years, many of us on this paper and many people not included in this particular work have been collaborating on multi-institutional descriptive studies, retrospective cohort studies, really just describing each neurosarcoidosis phenotype in an organized fashion, discussing the range of clinical presentation, symptomatology, imaging features, CSF data. How often is somebody with neurosarcoidosis, optic neuritis actually displaying lymphocytic pleocytosis? What does the glucose look like in certain phenotypes? So we're moving ahead together. And I think that's what we really need to keep doing because, as you mentioned, even in one center, one large academic center, it is not likely to have enough patients to truly power a study. So I think that's point number one in terms of really using a multi-center approach is going to be key here. I think the other thing to really think about, and it's certainly a work in progress, is defining the best objective marker that we can use to really track treatment responsiveness. So in some of these retrospective studies that we are working on, even presently, we use MRI. And MRI has its limitations. At present, the variability at which somebody undergoes a repeat MRI after treatment has some differences according to each case, really, not even just institutional practice alone. So in this paper, we propose that every 2 to 6 months, someone should get a repeat MRI with gadolinium. But even within this paper, we're still allowing this range, right? We're not saying everyone needs a scan every 3 months. Like, we're not committing everyone to the same exact surveillance. But I think we need to be a bit more standardized in how we're going to objectively monitor these patients. So that way we can determine the appropriate sample size and power the study appropriately to be sure that when we can move forward, we have prepared ourselves as best as possible to leave as little room for error as possible. And maybe MRI is not going to be that objective answer, or maybe it won't be the only. And we need to also incorporate clinical function scores as a sub-analysis category. And in the retrospective studies that are out there and that are currently in progress, we certainly are trying. But even within this realm, the modified Rankin scale score, for example, or the expanded disability status scale, commonly referred to as the EDSS, they don't fully encapsulate what neurosarcoidosis can leave a patient with in terms of a neurologic sign on exam or a symptom, and at times can also falsely conflate the disability score based upon comorbidity. So some of these patients have neuropathy from diabetes, and it's not their neurosarcoidosis that drives it. So it's so challenging to even define a reliable functional score clinically. And so there's a big movement amongst many of us to try to devise the best clinical function scale that we can think of that most appropriately captures neurosarcoidosis, because I think we're going to need more than just an imaging marker to assess treatment response. We're going to need some sort of clinical marker, something that's impactful to the patient, and that's practical in terms of what is the experience when there is treatment response? What does that mean? You know, it's great to make contrast enhancement go away, but if that doesn't equate to a very meaningful clinical outcome, then it's hard to argue that that's the primary outcome we should be looking at here. So there's a lot of brainstorming, and again, taking us back to collaboration that needs to be going, not only to power this study together, but to work together to really define what would we be looking at. We have the medications that we know can be helpful for neurosarcoidosis. So now how do we study them prospectively? And what are we going to use to mark that response? Should it be imaging? Should it be clinical function scores? Should it be patient-reported outcomes?
There is still so much room for refinement and further delineating that art versus science of medicine. Giovanna, thank you so much for your time. Again, if you want to read the paper in full, which I strongly encourage, in Green Journal, it is titled Consensus Recommendations for the Management of Neurosarcoidosis, a Delphi survey of experts across the United States. Thank you so much.
Thank you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.